And Dr. Kaiser, I will turn it over to you.
Wonderful. Well, I'm Sasha Kaiser. I'm the Associate Medical Director at Washington Poison Center, and it's my honor to welcome you all to the 4th Annual Overdose Awareness Series. Over the next 3 days, we will collectively strive to raise awareness, foster understanding, and inspire action in the face of an epidemic that demands our attention. In a world where the stigma surrounding substance use and addiction persists, it is all the more imperative that we come together to acknowledge the reality of overdose and its devastating impact. We stand here not only to remember the lives that have been tragically lost, but also to celebrate the strength of those who've survived and to strengthen our resolve to prevent future loss. Overdose is a silent crisis that knows no boundaries. It affects people from all walks of life, regardless of age, socioeconomic status, gender, or background.
Recording in progress.
It tears apart families, shatters dreams, and leaves a void that can never be truly filled. But we are not here to dwell solely on the sorrow. We are here because we believe in the power of awareness and education to bring about change. Through sharing stories, exchanging knowledge, and engaging in open dialogue, we aim to dispel the myths and misconceptions that perpetuate the stigma surrounding overdose and addiction. By fostering an environment that perpetuates the compassion and empathy, we can pave the way for healing and recovery while working together to shape policies and practices that prioritize prevention, treatment, and support. Throughout the conference, you'll have the opportunity to hear from experts in the field, gather resources, and educate yourself to provide the best care that we can for our community. As we gather here today, let us remember that overdose is not just a statistic. It represents lives lived, dreams unfulfilled, and potential unrealized. Each life lost is a stark reminder that there's much work to be done, but it is a work that we can accomplish together. Let this conference serve as a rallying point for change, a catalyst for unity, and a beacon for hope in the face of darkness. Thank you for being here, for lending your voices, and for your commitment to creating a world where the tragedy of overdose is replaced by a chorus of support, understanding, and healing. Together, we can make a difference. And with that, I'd like to turn it over to our event organizer, Megan King.
Thank you, Dr. Kaiser. That was a very powerful introduction. Welcome, everyone. My name is Megan King. I use she, her pronouns, and I am the Communications and Public Relations Specialist at the Washington Poison Center. I am one of the organizers of this series alongside my colleagues, Alex and Justin. Their faces aren't on this webinar right now, but you will see them in your sessions. You'll interact with all three of us through chat and through Q&A. So big shout out to both Alex and Justin for all of your hard work throughout this series. Before I turn it over to our first keynote speaker, Dr. Winkler, I'm going to cover a few housekeeping items for the series. First and foremost, a big thank you to all of our wonderful speakers who are donating their time and their expertise to make this series our best one yet. This is our 4th year, and this is truly, I think, the most incredible year that we've had. We have such a fantastic spread this year of different topics, different professions, and even geographical areas. We have speakers from 6 different states here. If you have attended this series in the past, you'll notice that this year looks pretty different. And one of our biggest changes was the addition of 2 educational tracks. We have a community health track and a toxicology and pharmacology track. Sessions within the community health track are accessible by public health practitioners, service providers, really any individuals who work with communities. And then sessions within the toxicology and pharmacology track are designed for healthcare providers and other clinicians. There are no prerequisites to join either track. All attendees are welcome to join all sessions, and some sessions are even listed under both tracks. You'll be able to see those in your agenda on Whova. So we have a lot of sessions over the next 3 days. So I highly recommend reviewing the agenda ahead of time and adding any sessions that you're interested in viewing to your personal agenda. All sessions are going to be on the Whova platform, not in Zoom. So when you enter a session, you'll see 4 tabs on the right-hand side of your screen. You'll ask any questions you have for our speakers in the Q&A tab. You'll participate in any polls that our speakers have in the poll tab, chat with your fellow attendees in the chat tab, and then that last tab is the community tab where you can share articles with each other, resources, you can connect with each other. There are discussion boards. So there are already some really great discussions going on about prevention and harm reduction. So I highly recommend you go check them out and chime in with your insights. All sessions will be recorded. The recordings and slides will be posted in this platform by early next week. So you will access them just like you are today by going to the session that you want to view, and the recording will be there. We do not have CEs or CEUs available this year. However, if you watch a minimum of 5 live or recorded sessions by September 15th, you will receive a certificate of attendance. Last couple things here, we'll be sending out a survey at the end of the series to get your feedback and any ideas that you have for future sessions, for future speakers. Please fill this out so that we can make next year's series even better than this year. And finally, for any questions about the series, please reach out to myself, to Alex, or Justin through Whova messages or email. All right, that is it for housekeeping. So now we can start our first session, our keynote address of the day. I am very excited to introduce you all to Dr. Gary Winkler, who will be discussing LGBTQ+ patient care and common drugs of abuse within LGBTQ+ communities with us. So Dr. Winkler is a board-certified medical toxicologist and emergency medicine physician. He has a passion for diversity, equity, inclusion, LGBTQ+ patient care, and medical toxicology. Dr. Winkler serves as the co-chair for the American Academy of Clinical Toxicology's Diversity, Inclusion, and Equity section. He's currently based in Houston, Texas as an assistant professor of emergency medicine and is the section chief of toxicology at the University of Texas Health Science Center, Houston. Welcome, Dr. Winkler. You can pull up your slides and I will turn things over to you.
Cool. Thank you for the introduction. Let me share my screen. Okay. So, as I was introduced, my name is Gary Winkler. We will be talking about LGBTQ patient care and also drugs of abuse in the LGBT community. If y'all can hear any feedback, I have my laptop, iPad set up directly next to me, and I'm hearing a teeny bit of feedback from me. If anyone can hear anything on the actual recording, just type in the chat. Okay. And let's get this started. So I first have no disclosures. I have no conflict of interest. I occasionally may shorten LGBTQ to LGBT. Sometimes I will be very specific with my language. I do not intend to leave off any letters to ostracize a part of the community, but saying the entire alphabet acronym is very long, and I will be very tired by saying it at the very end. So all of the views, opinions throughout this entire presentation are mine and do not represent the university that I currently practice in Texas. And the reason why I bring this up is about a month and a half, 2 months ago, the state of Texas passed a statewide ban on all DEI offices and programs at every single public university. Anyone who participates in things like this can be sanctioned and fired. My department is actively trying to fight this. However, places like University of Houston have just overnight had their LGBT offices closed. So this is something that we are facing in Texas right now. So first, why is this topic important? So JCO came out in 2014 as well as 2013. Give me 1 second. Let's see if that works. Okay. Sorry, we were just trying to fix my audio on my computer. So basically, JCO in 2014 said that LGBT patient care is important. They also came out in 2023 saying similar things again, and also creating a field guide of what can we do in the future to help this patient population. Beyond that, this is an under-talked subject that a lot of people don't know about. I know in my medical training, the only time we learned about LGBT patients was when we were talking about HIV and drugs and medical conditions associated with AIDS. That is our only education. Things have been changing over time. This patient population is very diverse. That the approach to a normal vanilla cis gay man is probably not going to be the same approach to a trans Black woman. They're going to require certain different nuances and ways to approach people that hopefully I'll be able to talk about by the end of this presentation. And then finally, you will care for these patients. If you don't care for these patients because they're not a clinician, you'll see these patients in your day-to-day, you'll interact with them. And this is just good knowledge to have at baseline as a human being. So my learning objectives. This is a very old slide and a remnant of when I would teach physicians, but it kind of provides a good framework of what we're going to be talking about. So I like to call this lecture LGBT 101 all the way to like 405. We're going to be covering the basic things that almost everyone should know. And people are going to be like, well, you're telling me what gay means. And then we're going to be talking about the really high level stuff. So it's going to be a broad swath of topics. We're going to be understanding the demographics and population changes of LGBT people within the last several years, decades. We're going to be understanding how to enhance our communication so that we can provide better healthcare, better serve these people. We are going to understand different best practices and how we can help these people. And then we're also going to understand different common drugs of abuse, what patterns exist within these communities, and also very specific drugs that are used within this community or these communities that are not necessarily used in our cis heterosexual communities. So who am I? So y'all already heard about like who I am now, but I want to talk about how I got to where I am. So I was raised in Texas initially. I came out when I was 17. I took a guy to prom in a Dallas suburb. So I used to be fat. I used to be about 200 pounds. I'm closer to 150, 60-ish now. But the guy who I took, his name's Jose. Sweet guy. But we went to prom together. We had no problems whatsoever, and no one batted an eye. I then did my undergrad at Trinity University in San Antonio, which is actually not a Catholic university. It's non-denominational and only has like covenant relationship with Protestants. Then I did medical school in San Antonio. I created the first, or helped create the first LGBT physician group in Texas that is still active to this day. We laid the groundwork to create a free LGBT clinic in San Antonio run by medical students and the local medical school that is still active to this day. My little puppy Annie is up there. She's still alive. She's 13. She's currently at the vet getting some routine blood work. Then I moved to Boston for my general surgery training. I then went to U of A in Tucson. And then is when I started to kind of get back into DEI. We created an LGBT curricula for our residents, faculty, that is actually still continued to this day. Some of the slides in this presentation are actually still from that old presentation. Most of them not, but a few of them are. And I just want to point out something that I did. I wore a rainbow flag badge reel. So because of my efforts and my colleagues' efforts with time, it's very common that all residents in the emergency department have pride flags, trans flags. Most residents have their pronouns just listed on their badge, and that's very commonplace. And we'll get into this, but those are little subtle cues you can give to the patients that they're okay, they're accepted here. They can feel at home. So then I went on to University of California, San Diego, where I did my medical toxicology fellowship. And on the bottom left is me and two of my colleagues. On the bottom right is Black's Beach, which is one very pretty beach, but also one of the few nude beaches in the Southwest. Absolutely beautiful beach, no kids. So there I then got more interested in DEI and how the intersection is with toxicology and how does it affect our patients. And one interesting thing that I've faced with time is, why do we need DEI in toxicology? Poisons are poisons. Poisons affect everyone. But I think any of us can say that different populations have different exposures and have different risk factors when it comes to different poisons, intoxications, what have you, that we have Chinese herbal preparations, we have Ayurvedic medications, that there are different things that go along with that. And then also different patient populations, so like gay, trans versus straight. The drugs of abuse are going to be different, and how they're going to do things and why they're going to do things are all going to be different. So that's when I really started to focus more on that. And then finally, I moved to Houston to start a job where I currently am with my partner, who's on the bottom right. Occasionally, you may hear him making fun of me in the background. And that's his sister. So who am I? So I am a cis white gay man. I am like the Wonder Bread in the rainbow. That being said, this presentation is not only my story, it's the story of everyone else. I'm here to tell our story so that I can reach a broader basis to help everyone in my community. And I'll say every single one of my slides probably has an anecdote about my life or about my friends' lives or something I've seen. So that's why I introduced myself, so y'all can see where I am coming from, so that then we can actually talk about and frame this entire presentation. And I also, this is another thing I like to do. I like to put the butt of the joke at the very beginning. So our summary slide, and we'll talk about this again at the end, that the LGBT patient population, EQ patient population, is a diverse group. By and large, they have a higher prevalence of medical comorbidities, including diabetes, hypertension, substance abuse, psychiatric disorders, and other infectious diseases like STDs. All of these problems are magnified in people who are elderly and people of color. And the youth have their own special health problems that we're going to be talking about. The best way to approach all these patients is treat them like a human. A supportive, caring attitude matters. And if you don't know, you can always ask. If you don't know someone's pronouns, just ask. You're going to hear me say that like 20 times today. And then subtle nonverbal cues. So pride flags around the department. You wearing a pride flag, you introducing your pronouns when you say hi to someone, opens up a dialogue and room for communication that is going to make them feel more comfortable. And then also don't out someone. You don't know who is going to be out, who's not going to be out. What story do they have to protect themselves, the people around them? You can always ask who people want to be involved in their care and speak to people alone. And then at the end of the day, a lot of the time, people's sexualities don't matter. I had a patient with a stroke last night who wanted his partner to be in the room, and then they came in with their grandchild. It didn't matter that he was gay and his partner was there. All it mattered was, hey, he was having a stroke. So let's get started. And as Mama Rue said, racers, start your engines, and may the best drag queen win. So we're first going to talk about the very, very, very basic terms. So first, what is sexual orientation? So sexual orientation is what you like, and it's based off of what your gender is. So we'll get into gender in a second. So what is heterosexual? Heterosexual means someone who is attracted to the gender that is opposite of them. So for example, I'm a gay man. I'm attracted to other men. I am not attracted to women. If I was attracted to women, I'd be heterosexual. Because I'm attracted to men, I'm a homosexual, meaning I like the same. Person who is bisexual likes both. These are a very reductionist approach to talking about sexuality, because really sexuality is a continuum, that someone can be predominantly heterosexual, but may occasionally have liaisons with men or the same sex. Some people may be asexual, meaning they don't like anyone. Some people may be attracted to everyone, and it doesn't really matter what their gender is. It matters who they are and what they are. So now talking about assigned sex, this is what you were, when someone popped out of the womb, what they were assigned at birth, and it's on their birth certificate. That may be different from what they identify as. So talking about gender expression, which is different from gender identity. So gender expression is how a person expresses themselves. So this can be all the way from masculine to feminine. So if I was to wear earrings or a dress, or other things that are not within the typical societal framework. You could say that that is not a different gender expression than what they have. So feminine versus masculine. Now talking about identity, gender identity is what I identify as, or you identify as. So cisgender means you identify with what you were born as, so what your assigned sex is. So that's why when I keep on saying I'm a cis man, so I identify as a man and I was born as a man. Someone who is transgender identifies as the opposite of what they were born as, or somewhere in that spectrum. Again, this is really hard because this uses a binary sex system, meaning male or female. Some cultures have multiple genders. They have 3 or 4 genders, not just 2, versus normal versus Western identification of what sex is. So trans, meaning you do not identify, or you identify as the opposite of what they are. Non-binary is someone who is on the spectrum and may not identify fully as cis, may not identify fully as trans. This can get a little blurry because some people will call themselves trans and then identify as non-binary, or they may identify as non-binary but not identify as trans. Again, this is all a continuum, and sometimes asking a person, it's like, what do you mean by that? I'm like, okay, that makes sense. And at the end of the day, the best way to think about most of these, so sexual orientation, gender identity, gender expression, is it's a spectrum. Very similar to our light spectrum and our rainbow. There can be people who identify somewhere on it. So I don't identify fully as a man. I don't identify fully as a woman. I identify somewhere in them there. I don't identify fully as straight. I don't identify fully as gay. I identify somewhere in there. And for anyone who likes chemical structures or likes to be traumatized by organic chemistry, I leave this slide for you. So what this is basically, this is a chemical structure. There are 2 molecules, cis versus trans. So I'll kind of explain this. So cis, meaning the things are on the same side. Trans, meaning they're on opposite sides. It's like trans fats. But that's kind of where the terminology comes from. So now talking about professional terms, we talked about more of the background terms. Let's talk about professional terms. So gender nonconforming is when someone is not conforming to the societal expectations of what they are. Partially goes into gender expression of what we were talking about before. Queer is an umbrella term that is used to, it's changed many times. So, previously it was a slur, and then now it's being reclaimed by our community. And it now can mean almost anything that is not straight cisgender. It can mean lesbian, gay, bi, trans. A lot of the time people use queer interchangeably with lesbian or trans, but for some reason the gay male community does not really use queer to identify themselves. Talking about gender dysphoria is the psychic angst, you can almost call it ennui, that someone feels because the way that they are is not congruent with how they see themselves. Okay, so for example, we have a person who identifies as a trans woman, meaning they were born as a man and identify as a woman, and they're a trans woman. And they're having to walk around in jeans and a t-shirt and having to present as a man. That may cause gender dysphoria and may cause psychic angst, depression, anxiety, what have you. However, not only is it about expression, gender dysphoria could be due to different body parts that a person has. So either do they have their birth genitalia, and is that causing them problems? And they would rather have something else that more confirms with their own body identity. Next is transitioning. These are just terms to use when someone is trans. The one thing that I have learned again and again is that it's not a gerund, meaning it's not ED. So it's not transitioned, it's an ongoing process of affirmation. So talking more about gender affirming surgery. So this can come in many places. So previously it was called sex dreams operation or some other term. The current term that is accepted is gender affirming surgery because we're trying to affirm the gender to the person's idealization of themselves. These are two terms to use when we're using documentation. So I can't write the person is a top or the person is a bottom, which we'll get into the next slide. Rather, they engage in anal-insertive, meaning they're putting a penis into an anus, or anal-receptive sex. So they're getting a penis stuck in them. There can also be things like cunnilingus, so that's oral sex, or other types of professional terms. So now we're going to talk about more colloquial terms. And after we get done with the terms, then we're going to start diving into data and a lot more fun stuff. But this is the background information, so no one's confused. So gay is a man who has sex with man, more or less. Lesbian is a woman who has sex with women. Sometimes gay can refer to homosexual women, but lesbian cannot refer to homosexual man. That's kind of the square rectangle argument. A top is someone who engages in anal-insertive sex. Bottom is someone who engages in anal-receptive sex. Someone who is a verse or switch is someone who can do both. And that's also something important to ask people. And this changes what different testing I will do for someone, or like their risk for HIV and what have you. A side is a newer phenomenon that basically means it's someone who does not engage in insertive or receptive sex as much. They more, if you want to think about it, like being on the side. And this was a cute little photo I found. Switch is more so a side in the, switch is kind of the term for verse in the lesbian community. And then Grindr. So we're going to talk about dating apps for a second. So Grindr is a dating mobile app that is used to connect people. There are many different dating apps. Jacked, Hornet, Scruff, Growler, I guess OkCupid, you could call it a dating app, but there's lots and lots of different apps, and every single different app has their own specific clientele, people that they're going to. So what does an app look like? Everyone's different. So most people will know like Tinder, where you like left swipe, right swipe, but a lot of the gay ones are a little bit more proximity based. So on this, it's called the grid. You see people based off of how close they are to you in descending order. When you look at someone's profile, it will show you, depending on how much information the person gives, their height, weight, what they want, what different communities they are part of, even when they might have last contested, what different social medias do they have. I haven't been on Grindr for the past 2 years, but everyone probably also has their OnlyFans linked as well. If not, then it's through Twitter. This person is specifically looking for meth and marijuana, which is also very common in these apps. And then talking a little bit more. So I showed you the G-rated grid. What you see a lot of the time is a sexualization of the app. So you're seeing abs, you're seeing pecs, you're seeing people who are displaying their body. I will probably say that this photo received and the bottom photo received is probably sexual body parts. And that is very common within this. And when we were talking about the different apps and the different clientele, there's also a different reputation of the different apps. So things like Tinder is just more of the people who are trying to get in a serious relationship, whereas Grindr is more viewed as a hookup app. So different apps have different connotations associated with them. And now that we've talked about apps and we've gone on that side rail, let's talk about terms to avoid. So first is talking about and using gender affirming surgery as saying a sex change or asking if someone is pre or post-operative. The only time that I care about a person who is if they're pre or post-operative is if that surgery or the organs associated with that surgery matters for my differential diagnosis in treating the patient. And at that point, I'd ask, what surgeries have you had? Because I'm concerned about blank. We already talked about transgendered, tranny. Don't use that. Don't say he, she. Don't say it. Don't, if someone is starting to use words in quotation marks, that's also something to avoid. That, how do you have sex? What body parts do you have? Have you had the surgery yet? What is your real name? Which that can be hard when someone's registered under John and their name is actually Betty and John is their dead name. Just to briefly say, what is a dead name? Dead name is the name that you were born with or went by and that you don't really identify as anymore. So Ellie, the one from Juno and Umbrella Academy, they went from Ellie to Elliot Page. Ellie would be their dead name. Elliot is their name. So just an example of what a dead name is. So now let's talk about demographics. And a lot of this data is going to be based off of current data. So back in Kinsey, this was years ago, he said that approximately 10% of men are gay and 5 to 6% of the population of women are gay. And that recent studies have shown that it's closer to 1.6 to 3.5% identify as lesbian or gay, 0.7% identify as bisexual, and approximately 8.2% of people have had a same-sex encounter, and 11% have some attraction to the same sex. Doesn't necessarily mean they're gay, because remember we were talking about a spectrum of sexuality, but that they've had some attraction to the same sex. A recent 2011 study has said that approximately 0.3% of US adults identify as transgender, which approximately is 1.4 million people. So this is a new piece of data that just came out. But what we're seeing is that over the past 10 years, we've had a slow uptick in the amount of people that identify as lesbian, gay, bisexual, or transgender, or basically anything besides heterosexual. And we've seen it go from about 3.6 in 2013 to about 7.2. And the newest data that I just updated was that 2022 has now stagnated at 7.2% of people identify as somewhere on the queer spectrum. What we do see, interestingly, is that more contemporary generations identify as LGBT or T at a higher rate compared to older generations. So we have the Gen Z, baby boomers, traditionalists. And for people who are Gen X, I'm sorry, I'm calling you old, I'm a millennial. But Gen X does identify less as LGBT compared to millennials and compared to Gen Z. What we also saw over a 5-year period was a substantial increase in Gen Z who identify as LGBT as they're coming of age and maturity. What we're also seeing is very similar things, that more of Gen Z is identifying as LGBT, less are identifying as heterosexual compared to baby boomers, traditionalists. And then we're even seeing a similar breakdown of the actual bisexual, gay, lesbian, or transgender, that the amount of Gen Z, more are identifying as transgender compared to millennials, same thing with lesbian, gay, and a lot of people are identifying as bisexual. And this was a Gallup 2021 poll. A lot of this data is going to be coming from Gallup. What's the sexual orientation? Which of the following do you consider yourself being? So again, we're seeing similar things, that this is just general population data, that bisexual is 4.2%, gay 1.4%, lesbian 1%, and transgender 0.6%. This was in 2022. So what is the bottom line? And the bottom line is that the proportion of people US adults who consider themselves LGBT has grown at faster years compared to prior years. And that this is final. And what's happening is that Gen Z is reaching adulthood, that people are coming of age, they're finding out their adult self, and they're being able to live in a less restrictive environment. Now, the interesting thing is, what about cultural acceptance? What has happened with cultural acceptance over the past several years? So we have seen since 1994, and there was an inflection point in about 97, where prior to 97, they thought the society as a whole in polls thought, and this was Pew Research Center, thought that homosexuality should not be accepted by society. Inflection point came in 97. I'm not sure what happened in 97. I don't know if that was the Ellen DeGeneres era. I think that was a little early for Ellen. But really, we saw in the late 90s, there was a change. And then over the past 20 years, we have seen increasing social acceptance by society for homosexuality, which is great. We had gay marriage passed, what, 5-6 years ago? That people are slowly starting to say that gay marriage is okay and acceptable. Well, that seems great, right? I don't know if anyone's been paying attention to the news recently. When I last made the presentation, this was the slide we had. However, something new happened. Within the past year, the social acceptance of gay marriage, and I'm using gay as a general term here, has decreased over the past year. Not only are we seeing it in people who are conservative or vote conservatively, but we're also seeing it in people who vote Democratic and vote liberally. We're seeing both. That overall, it seems like there's been a little bit of a shift in acceptance of LGBT people and marriage for those people over the past year, 2 years. So maybe we're in a new changing period where it will become less socially acceptable. And I know that the news cycle is to the point where everything, drag shows are now getting banned, that we can't. I'm concerned for my safety, and attacks are going up, and we're having increasing shootings in gay clubs, that maybe the pendulum is swinging the other way. So now that we've talked about demographics and marriage, and now that we're seeing increasing rates of identification in people, let's talk a little bit more about healthcare, because that's why we're here today. So I'm going to come back to this theory many times throughout my presentation, and it's kind of the overarching theme of why we see what we see. So I believe this was in the 90s, but Dr. Myers came out with what he described as the minority stress model. And what he said was that perceived stigma that a person feels, that they're perceiving stigma, enacting stigma that someone is feeling upon themselves, and then also the own internalized homophobia that someone has and the negative self-thought that they have, all creates chronic stress. And that chronic stress identifies as higher levels of anxiety, or basically manifests as higher levels of anxiety, depression, other healthcare problems, which sounds like it makes sense. And we can all see that. We can see that in people of color. We can see that in other minority groups. That kind of all makes sense. And what this all leads to is healthcare disparities. So now we're asking, how does this manifest? And what we see is we see psychological illnesses and substance abuse that arise from, or we will say that we see psychological illnesses and substance abuse that arise initially because of the chronic stress and everything else in the Myers minority model. And it comes from the increased stress of nonconformity. So basically the societal expectations and the pressures that are put on this group leads them to have increased psychological illnesses and substance abuse. that it's not inherent to sexual orientation or gender identity itself, that it is a byproduct of the stigmatization of that population. And what we actually see is that, so we have minorities of minorities here. So sexual minorities in areas with high prejudice have a 12-year shorter life expectancy compared to their cohorts in more tolerant areas. So that's kind of where we can see that this idea seems plausible, that rates of suicide, homicide, violence, and cardiovascular disease were higher in these stigmatized populations compared to the non-stigmatized populations. The other things that we see is these people are underinsured compared to the non-stigmatized populations or the heterosexual community. And also what we're seeing is that patients fear substandard care. That I forget how long ago the study was, citation 4, but basically that 56% of respondents reported harsh or abusive language from a healthcare provider, and 8% have been denied care. I can say I personally saw this in data that I collected in San Antonio, where people were saying that they felt uncomfortable with their healthcare providers. They would rather go someone who's open. They've been denied care. There was I think 2016 or 2017 article called "Sometimes You Feel Like a Freak Show" out of the Journal of Academic Emergency Medicine. And it looked at trans people and their healthcare experiences. They said the same thing. So it's not only one study that is saying people are getting harsh, abusive language, that they fear substandard care. There's multiple things going on, and this has been corroborated by multiple studies with time. So how are these people feeling discriminated against? And this is old. This is 2013. And we can say based off of prior slides that, hey, maybe things have changed. That being said, there's still going to be discrimination. And I'm using this slide as an illustrative point to show what people tend to experience. So subjects of slurs or jokes happened past year, happened sometime in their life, meaning 43% of people who responded to this study, so 1,200 people, said that they have had some type of joke or slur because of their sexuality, that they have been rejected by their family, that they have been physically threatened or attacked, which I have had happen to me, that I've been made unwelcome to feel in a place of worship. Okay, well, if I actually went to church, that would be different. They have had poor service at a restaurant, hotel, or other place of business, that they have been treated unfairly by their employer. All of these things are that discrimination that the LGBT community does face. So now talking about mental health. So I kind of told you everything was worse in the community, and mental health is worse. So this was a Pew 2023 study that actually just came out last month. But how would you describe your own mental health and well-being at this time? Self-described, how would you describe it? Of the straight community, 17% said excellent, 46% say good. However, when we're talking about anyone in the queer community or not straight community, what we're seeing is less people are saying good, or less people are saying excellent, less people are saying good, and more people are saying fair or poor. The person's own thought about their healthcare, not a clinician's thought, but their own thought is that it's worse. And then what symptoms are these people having? So increasing rates in anxiety, stress, loneliness, decreased happiness. And all of these are things that young adults, so Gen Z, is feeling. And then also how you describe your physical health. That is a different slide, but how you describe your physical health. And then again, lesser points of excellent and good, and more people that are saying that it's only fair in Gen Z. So now the next question is, we've talked about all the theories of what people experience and how they experience it. But what do our patients actually experience, and what do people actually experience? So I'll kind of start off and say that bisexual people I don't have a slide on, but they are similar to how they identify with. So a bisexual man would be similar to a homosexual man, and a bisexual woman would be similar to a homosexual woman. So now talking about, we have dating apps which cause its own level of stress, anxiety, and STDs and other problems that can come from them. There are high rates of substance abuse. On the dating app, it's pretty common to see different emojis that mean different things. People who want to party, which means meth, Tina, who want to have chemsex, who want to use meth, marijuana, cocaine, heroin, LSD, what have you, while hooking up or going out or doing things. We're just basically seeing increased rates of substance abuse. We're seeing higher rates of anxiety, depression, and suicide in homosexual men. We are seeing increasing rates of eating disorders in homosexual men compared to heterosexual men. The eating disorders that we more commonly see in homosexual men are more of the restriction purging type behavior rather than the binging type of behavior. We're seeing increased rates of substance abuse and abuse, which we'll get into much later in this presentation using actual data. We're seeing higher rates of STDs. So not only do we know that, yes, homosexual men have HIV, we all know that, and we're going to get into that. But what we see is we're seeing people use PrEP, so pre-exposure prophylaxis, to prevent the transmission of HIV. In the process, what we're seeing is we're seeing increasing rates of every other STD in homosexual men. And the reason why is with PrEP, transmission of HIV is almost zero. So the prior trend of using condoms to prevent HIV transmission doesn't matter anymore. That gay men aren't going to get pregnant with each other, so they don't have to worry about condoms. What we're seeing instead is the transmission of other STDs, chlamydia, gonorrhea, syphilis instead, and decreasing rates of safer sex. There's actually a change in the past decade or so that pornography everyone used to use condoms in professional pornography. And now finding a studio that uses condoms is very rare. And that's kind of the changes in cultural expectations and norms within the community. Next, what we're seeing is, again, rates of HIV are higher in homosexual men compared to heterosexual men. And then also people of color are disproportionately affected within HIV incidents. Hep A and Hep B, more common as well. Higher rates of HPV and anal cancer because of anal receptive sex. Now talking about issues that we see in homosexual men. So a lot of these are going to be very similar to homosexual men with a few different caveats. So homosexual women are less likely to receive preventative care, less likely to have insurance similar to homosexual men. They have higher rates of cervical, endometrial, as well as breast cancer. Some homosexual women do have children, which are protective factors for these. However, a decent proportion do not. And so rates of cervical, endometrial, and breast cancer are higher in this population. There's higher rates of obesity, which leads to hypertension and diabetes. Before, we were talking about higher rates of eating disorders in gay men, where it's more purging and restrictive, whereas the eating disorders that we see more commonly in homosexual women are more of a binging type. We have increased rates of mental health disorder. Again, eating disorders we just talked about, anxiety, depression, suicide. STDs can happen with sharing toys, sex toys, and also decreased preventative healthcare. And then higher rates of vaginal bleeding that go along with less likely to receive preventative care and more likely to have gyne cancers. So talking about mental health now. This was out of the SAMHSA 2023 data, and we'll get into a lot of this data in a little bit, but this is reporting any mental health disorder whatsoever, and any serious mental health disorder is something that interferes with normal life. And so what we see is that in the LGB community, we have higher rates of both serious mental health and any mental health conditions compared to their straight colleagues. Yeah. Now talking about HIV data. So this is the general HIV risk for a person in the US. So if you're a man, you have a 1 in 64 chance of getting HIV. If you're a Black man, 1 in 22, Hispanic 1 in 51, Caucasian 1 in 401 or 400. Women 1 in 253. Black women again are disproportionately affected compared to white women, Hispanic, Asian, Pacific Islander. So we're seeing overall that women are less affected by HIV, however, compared to men. However, the African American Black community is more heavily affected. These are good data that I always tell residents that what is the risk of contracting HIV for someone who is positive and someone or seropositive and someone who's seronegative, and that the highest rates occur for vaginal sex and lower, so penile inserted vaginal intercourse, lesser rates for receptive penile vaginal, and then lower rates for receptive anal, and then also slightly higher than receptive vaginal for anal insert. All of this is pretty low percentages, still risky chance. And then also when people are receiving or giving oral sex, that's a lot lower. Now talking about our men who have sex with men HIV community. So a Black man has a 1 in 2 chance of contracting HIV during his life. But Latino men have a 1 in 4 chance. And white men have a 1 in 11 chance. And this is all men who have sex with men. So what we're seeing is that men who have sex with men are 83 times more likely to contract HIV compared to their straight colleagues. Wild data here. But how can we prevent the transmission of HIV? We were talking earlier about pre-exposure prophylaxis. So this is Truvada. This is emtricitabine and tenofovir. It is manufactured by Gilead out of San Francisco. Pre-exposure prophylaxis, the 2 main oral ones we use are Truvada and Descovy. Truvada is now generic and really cheap. Descovy is still brand name. There are newer formulations coming, like you can do an intramuscular injection that you only need once every month or like once every 3 months. So you don't have to worry about taking daily pills. As of a month or 2 ago, the United States Preventative Services Task Force came out that pre-exposure prophylaxis is a grade A recommendation for HIV prophylaxis, prevention prophylaxis, and someone who has a higher risk of contracting HIV. And we'll get into what the populations are in a second. So what are our candidates? So our candidates are people who engage in risky sexual behaviors. So men who have sex with men, anyone who is having multiple sexual partners, who even heterosexual women who are going out and having sex with multiple men, people who make money by selling sexual services. Pre-exposure prophylaxis has been used by women in Africa. People who use IV drugs are also candidates for pre-exposure prophylaxis. There is basically anyone who is at a higher risk of HIV is a candidate for pre-exposure prophylaxis. What are the downsides? So main downsides with Truvada and Descovy are GI upset. Some people have vivid dreams. Long-term risk of Truvada can be osteopenia, so decreased bone strength with time. There There can also be some liver enzyme elevations with Truvada. Descovy, which is very similar to Truvada, can have kidney problems as well long term. But these are older studies, but basically showed that using Truvada had a decreased rate of transmission of HIV by 92%. People who actually took the medication daily had a decreased transmission by 99%. That medication is the most efficacious if it's taken every single day, but sometimes patients do miss doses. The downsides of Truvada is that when people are using pre-exposure prophylaxis, they're less likely to engage in other safe sex behaviors, meaning they're less likely to use condoms, and the populations who use PrEP have a 72% chance, a greater chance to get other sexually transmitted infections compared to the people who don't use pre-exposure prophylaxis. And this is just talking in general, that in a serodiscordant relationship that is having sex regularly, so someone who's HIV and HIV negative, not using protection, there is a 0.5% transmission rate yearly. And this is with someone who has an undetectable viral load, so very well-controlled HIV. I'm not saying that people should be engaging in not safe behavior of someone in a serodiscordant relationship, but it is possible. And this is one of the partners is not on PrEP, one of them is on true antiretrovirals for their HIV. So earlier we're talking about Grindr. So even though I was slandering Grindr, and please don't come after me, legal people, but Grindr and other dating apps have baked in when you were last tested, are you on pre-exposure prophylaxis or not? What is your HIV status? What is your viral load? I mean, again, you can lie on all of this. You can ask, what safety practices do you want? You can even figure out different local resources in some instances. Really cool things. And then on the right-hand side is Scruff. So this is a website that is more geared towards hairy or burly men. So as a recap for issues that we see in gay and lesbian people. So both are less likely to have health insurance, or there's higher rates of eating disorders in both communities. Gay men are more purging, lesbian women are more binging, which lead to obesity. Both have higher rates of STDs in both populations. Lesbian women have higher rates of postpartum depression, which again, lesbian women can still get pregnant. Higher rates of mental health problems, higher rates of substance abuse in both populations, higher risks of asthma in both populations. This one's really interesting, and it's probably not because of drug use, but you could probably go with the Myers stress model of like, is the asthma related to chronic stigmatization and health manifestations of that? And I would go with yes for asthma, because there's no other reason why both of these populations should have higher risks of asthma. Higher risks of gyne cancers in lesbian women, higher rates of anal cancers in gay men, and then a few other things. Gay men, because they're engaging in analinguists, they can have higher rates of other infections caused by fecal oral transmission, so Giardia and some of the hepatitis. And then also 75% of new cases of syphilis are in men who have sex with men. But we've talked a lot about lesbian, gay, and bisexual people. Why don't we now talk about trans people? I honestly forget when this was from. This was in front of the Texas State Capitol. And it was probably like 2 years ago at this point, talking about trans youth and how now parents are going to be taken to court and kids are going to be taken away because parents are trying to do the best thing for their kid and their kid's mental health. So talking about trans patient healthcare. So again, less likely to present early, more likely to present later, less likely to have receive preventative care and have undertreated conditions. These patients potentially have body parts and elements that are not congruent with their gender identity. So getting back to what we were talking about, trans people. So a trans woman is a person who was born as a man and is transitioning to a woman. They likely still have their penis. They likely still have their prostate. They likely still have their scrotum and testes. They probably still have facial hair, other things that are very masculine. A trans man, so female to man, FTM, they may still have a uterus, they may still have a vagina, they may still have their breasts, they have their ovaries, they have other things that are congruent with their birth sex. So my point is that everyone has different organs wherever they are in their process. Some people may have things, some people may not want to have things. It's sometimes easier to ask, what organs do you have or not? In the context of saying this is for your healthcare. So there's if a person can't get into a doctor, can't get gender affirming care, they may be widespread self-medication with hormones, so either testosterone or estrogens. We do not currently know the long-term effects of different estrogen testosterone products. And by long-term, I mean decades long. So someone who's been on it for decades, not a year or two, but for 30, 40 years. We see higher rates of HIV, STD, suicide, and victims of homicide compared to both heterosexual people as well as LGBT people. We see higher rates of violence and victimization. And then we also see greater rates of home, or what I see in Texas is people who go to Mexico or some other South American country and get poorly done plastic surgery. And then they have complications because of that. You can also have injections, pumping parties. All big term, long-term complications that come from these are infections, disfigurement, deaths. So people, if they have silicone, can have small little fragments of it break off and go to the lungs and cause a pulmonary embolism. Talking about hormones, and we're not going to go into too much of this, but what we see is, so trans men get masculinizing hormones, trans women get feminizing hormones. Trans women will also get testosterone blockers too. So what we see is basically everyone goes through puberty again. So if anyone remembers how bad puberty was, imagine going through it when you're 20 or 30 or 40 or 60. So it's miserable, from what I understand. But the long-term effects that we see is the risk factors actually tend to approach what the hormones' genders are. So the risk factors that a trans woman sees and the effects that a trans woman sees, it's closer to what a what a birth cisgender woman would see. So they can see DVTs, they can see gallstones, they can have liver enzyme elevations, they can have weight gain, they can have high triglycerides. Trans men can see heart attacks, weight gain, male pattern balding. What we see and the complications from it is what we see in the cisgender population that has had those hormones for their entire life. And then briefly talking about gender affirming surgery. So the best ways to think about it is creating something or taking something away. So for example, we have things like mastectomies, where we are removing breast tissue. We have things like a phalloplasty, which means basically creating a penis. Metoidoplasty is basically cutting the ligaments that surround the clitoris that and when a trans man undergoes hormone treatment, what happens is their clitoris actually becomes enlarged and more phallic-like, it's like a tiny penis. What they can do is they can actually cut the ligaments of the penis, of the neopenis, the clitoris, and basically make it larger. Scrotoplasty is where they are creating a scrotum, and vaginoplasty is where they are creating a vagina in a trans woman. And there's plenty of videos online, but you're turning the outside inside is the easiest way to describe what it's like. I know that is highly reductionist, but it is a good way to say. All of these things have complications associated with them. So infection, bleeding, things where people create a urethra, they can have strictures. These, for the most part, are highly intensive surgeries that require specialists. Other less severe ones are the conventional plastic surgery ones. So shaving of the Adam's apple, implants, shaving of the nose to create more feminine features or masculine features versus the other more intensive invasive procedures. And I'll also take a point and say that just because these procedures exist doesn't mean that they're procedures that all patients want. Some people are very happy with what they have, even in their current trans state. Some people are not happy, and that all feeds into gender dysphoria. As a clinician, it matters for me because I'm like, okay, well, what have you had happen? What organs do you have or not have at this point? And most of the time our patients are pretty astute. But let's say I have a trans woman who has not had any bottom surgery yet, and she is coming in with lower abdominal pain. One thing that I worry about is testicular torsion, so twisting of the testicle, which is very possible and something I worry about in all of my cisgender male patients. So now talking about trans documentation, and this is when things can get a little tricky. So I always use I document the person's preferred name. So I would specifically document patient's preferred name is Gary, not in quotation marks. I'm just using that as an example. I would put just in my note, patient's preferred name, Gary. Some systems have a built-in preferred name. Some do not. Epic can have that. Epic also has different colors to denote different things. So for example, I used to work in California and our hospitals had Epic. At our children's hospital, we had a lot of trans youth that I came into contact with because they were trying to kill themselves decently frequently. And they would have a color for their profile. So instead of being red or pink or blue to denote their gender, they would instead be purple, which means that they're somewhere on the trans, non-binary, queer spectrum. And it is a quick, easy reference point so that we can know. During sign out, I always mention this. On the tracking board, if we have a patient comments thing, I always mention it. I also document in my note, patient is a trans man, and then I put in parentheses, female to male, FTM, or trans woman, female, or that is a typo, trans woman, male to female. This really helps decrease the confusion with time when future people read your note, and it helps with communication. If we can establish what the person's gender identity is, what their person's name is, it really helps further patient care and it helps with communication. And then I always mention it during sign out. So I go around, I tell the techs, I tell the nurses, I tell anyone who potentially will interact with that patient. Pronouns, name, what have you. It's documented everywhere because it's important. And when I'm giving sign out to other teams that will be taking care of this person later, I mention it. Maybe I'm a little zealous, but otherwise we're misgendering the person. We're calling them by a name that they do not identify with. And it's going to ruin their experiences in the hospital and potentially cause them to have further angst and distrust in the system. So now just kind of best practices, talking about our patients. And this applies both for trans as well as lesbian, gay, bisexual, and other populations. So some people who appear gender confirming may be trans. You might not know that. They may be pre versus post. Some patients will be very forthcoming about that, but I've also had patients who were 20, 30 years into their transition. They are legally changed on their birth certificate and everything. And the only reason why we know that their trans status is because they tell them, it's like, hey, I'm trans. Respecting a patient's preferred gender identity. So what gender are they presenting as, or what do they want to be as? What if you don't know their pronouns and they don't use and they don't say, one thing that I will ask is like, hey, my name's Dr. Winkler, my pronouns are he, him, what's your name? And by me saying that, I am opening up the field to them to share theirs, to share their name and to share their pronouns so that we can communicate. It's also asked to be like, what do you like to be called? Honestly, I go with my name's Dr. Winkler, what's your name? Because then they say their name and then you're making sure you identify with their wrist strap. And if for some reason it doesn't match, like, hey, I noticed this isn't matching your wrist strap. What's going on with that? Or like, I noticed there's a difference and you said your name was this, like, and honestly, asking just general questions of like, out of curiosity, not bad curiosity, but like, hey, I'm just trying to figure this out for you. I'm trying to help you. Trying to be non-confrontational and helping the patient goes a long way. Next is I use gender inclusive pronouns. The number of times I misgendered a person's family member on the phone or what have you, you learn very quickly that it's easier to say, what does your partner do? They, them, using gender neutral pronouns and other nouns to identify people. Spouse is a good one because it's not husband or wife. If I'm getting a sensitive history, I always make sure that I say why I care about this. Why does it matter to the history? Why am I having to do an invasive physical exam? I also in patients always say like, hey, I'm going to listen to your chest, or I'm going to listen to your heart and lungs. Hey, I'm going to press on your belly. If I also be like, hey, I'm pressing on your belly to see if you're tender, or I'm listening, or I need to, someone who comes in with like a car crash. Hey, I need to press on your chest to make sure that you're not tender. Things like that, that explaining the physical exam and getting assent is important and gives the patients, empowers them. And this applies to everyone, I'll say that. Using gender neutral words to describe sexual anatomy. So instead of saying breast, chest. Instead of saying penis or vagina, you can say genitals, because some people may have some gender dysphoria with their genitalia, and you are reminding them of that. So, but basically what you're doing is you're avoiding gendering the anatomy and calling it by what its technical term. And then the other thing is that not everyone wants surgery, and it's not important to everyone, that we talked about before. And then again, what I was saying before is most of the time, why a person presents doesn't matter. Someone is coming in with chest pain and they're a trans woman. That really doesn't affect my workup. Maybe belly pain will though, because let's say we have a person who still has ovaries. Well, I can be concerned that one of their ovaries twisted. A person comes in with a broken arm. Well, I might actually care because I may need to sedate them or get x-rays or what have you. And could they potentially be pregnant? Because because a person is trans doesn't mean that they may not have baby making organs and be able to create a fetus. But that getting back to my point of like, I don't ask invasive questions unless it is clinically relevant and necessary to my chief complaint, to why they are here, and to my workup. If I have to ask an invasive question, I explain why am I asking this. Why am I going more in depth into something that may make you a little uncomfortable, but it is important to my care of this person? Okay. And then finally, team uniformity. We talked about that everyone is approaching the patient with the correct pronouns, with the correct name, and everything else. So communication tips, this is kind of going on the last slide that we were just talking about. Communicating in an open and inclusive manner, asking open-ended questions, creating a safe space for disclosure. And for me, that includes wearing rainbow flags, having flags on my ID. So during Pride, I went and gave every single resident, if they wanted, a teeny little Pride flag that they can put on their ID. So, and it's those subtle cues that let a patient know it's like, hey, this is a safe space. This is a safe person. Only once in my 10 years of having a Pride flag have I ever had a patient say something homophobic because of the flair that I have. And they were actually altered and confused. So I can't really give them too much frustration with that. Only once. That you will do much better for your patients by having that open line of communication to the patients who are disadvantaged and disenfranchised, and rather than the people who may be angry about it. I know that this is a Seattle and Washington, so I'm kind of preaching to the choir in this regard, but it still helps with patient care and communication. Next, if you're unsure of a pronoun, just ask. You can introduce yourself with pronouns that I just described a few minutes ago. I only ask what sexual behaviors or other things if it actually matters to the patient's presentation or not. And then using gender neutral pronouns to refer to someone's spouse, partner, even using they, them. Once someone identifies the pronouns of that person, then you can swap. And they start using masculine pronouns or what have you. Sure. Like, I'm not engaged or anything to my boyfriend. He's sitting over there, but people call him my husband. And I'm just like, no, sorry. Oh, he can hear me. He's shaking his head at me. And then the other important thing is asking who the patient wishes to have involved in their care, to be their medical decision-making. I will frequently kick out family members, and if I'm going to be discussing sensitive tests or questions, so there's some like, hey, I'm going to speak to you for a few minutes. I'm going to kick out your family. I do this routinely when I'm discussing sensitive topics. So let's talk. With a family out of the room, I'm able to talk to the patient like, hey, this is what we're going to be talking about. It's routine for me to kick out family. I do that all the time. I'll talk about this with you. And if you want me to talk about it with your family members when they come back in, I can. But just because someone's with them doesn't mean that that person is going to want them involved in their healthcare. And giant red text. A lot of the time, their sexuality and gender doesn't have anything to do with what is actually their chief complaint and problem. So how to be an ally. This is all kind of getting a little redundant, so we're going to breeze through this a little bit, but never outing someone. And a lot of people, it's a special thing for them. Sometimes people may be in the closet if they're young or old, and they may have created a identity that their family does not, or that they are portraying to their family. Practicing gender inclusive language, not asking invasive questions unless needed. If someone is around you at work saying homophobic statements, calling them out and saying like, hey, don't say that. Especially for my patients, if they say something about my patients like, nope, we are going to correct that. We don't do that. And then we already talked about ID flags, posters, little signs to a person that it's okay to be them there and they're accepted. So now we're going to talk a little bit about the special populations. We're going to go through the youth, we're going to go through people of color, and then we're also going to go through the elderly. So this is what we were talking about before. This is a slide that, or a diagram we've already seen, but the younger generations are identifying at a greater percentage, even with time, compared to older generations as LGBT. That most gay men identify some type of sexual attraction at 9. They start to have self-awareness of that sexual attraction by their late teens. Women who are attracted to women, 10 and 16. So very similar ages. Adolescents, 7 to 9% report as having some type of sexual encounter in their youth, whereas and only about 1 to 3% identify as LGB. That was much older data than this new Gallup poll. One problem is a lot of data lags, and very limited amount of people will actually share their sexual orientation with their physician. And that's just an easy question of like, if we have any pediatricians in the room, they'll all know what a HEADS exam is, but it's like a psychosocial assessment of pediatric patients that's done routinely. And parents get kicked out, and that's when you ask people. But it's an easy question of, when you're asking about sexual relations and what have you, do you engage in sex with men, women, both, or other? What type of sexual encounters are you engaging with or having? And honestly, asking those open-ended questions and seeing if someone knows them, and if not, then asking more pointed ones works well. And then younger generation, the sexuality is going to be more likely to be gender fluid. This is a little bit older. I think this is from 2016, 2017. But when did you first know if you were gay, knew for sure, and then when you told someone? What we see is most people have a first thought when they're 10 to 13. They know for sure when they're 15 to 17, and then they first tell someone when they're in their late teens to early 20s. And that's not uniform for anyone, that there are outliers that come in early, that come in late, and that's normal. But now you're asking, like, what do kids worry about? And so our non-LGBT youth, what we're seeing is that a lot of the kids in high school worry about their classes, grades, exams, worry about what they're going to be doing in college. Financial pressures related to a job or college or whatever. What do our LGBT kids worry about? So they worry more about their families accepting them, being bullied at school, and then fears of being out or in the open. Um, 20 to 40% of LGBT youth are homeless. A quarter of gay male teens have been kicked out of their house. So high rates of homelessness. 70% have received positive affirmations from their friends or family. However, an even greater percentage, 90%, have received negative messages. 25% have felt unsafe or bullied. So what we're seeing is a lack of social support for these people. And again, like, this is pre-Gen Z data. I would love to see newer data for Gen Z. It's just not out yet that I could find. Twice the rate of suicide. Greater rates of experimentation with drugs or alcohol, which I think we had a question about pre-session. Twice as likely to be verbally harassed. Higher rates of STD. Higher rates of HIV infections. And then 17 states have laws prohibiting bullying based off of sexual orientation. Few protect students from discrimination. And I'm not sure what the current data looks like on that. So all in all, what does this mean? And this is out of San Diego Pride, some kids, or I guess teens. 1 in 5 new cases of HIV are people in their mid to late teens to early 20s. 60% of those people are unaware and not being tested. Women are also getting infected with HIV. People are having to cope with internal transphobia and homophobia, and then also dealing with the external homophobia and transphobia that we talked about already, gender, eating disorders, and body images. And then sometimes hard to find support, finding a mentor. Like, I'll be honest, one of the reasons why I am out in public and myself and don't care is because there's going to be one little gay kid or trans kid who sees me living my best life, and I'll be able to be that positive image for them. And they're like, oh, they're doing good. I can do good too. And then other things are problems at school. So trans youth, this is a very contentious topic, and we're not going to talk about it too much. Trans kids can receive hormone therapy. Trans kids tend to know they're trans very, 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 very early. And we're talking about like less than 10, if not by teenagers. And there's a good argument for allowing a kid to transition prior to them going to their first puberty. And there's data to support it. But then there's also an argument of like, how about we just delay puberty, use puberty blockers, and allow this kid to mature emotionally, and then they can go through whichever puberty they choose later. And it's like using puberty blocking agents is well studied in precocious puberty already for indications we already use. And then we can delay the further medication management. Again, this is a really contentious topic. Me talking too much in depth into it and goes well over my head. One, because I'm not a pediatrician, and two, I don't specialize in this type of stuff. Now talking about the elderly people, I think this is in Boston, because those look like Boston brownstones in South End, but I'm not sure. So 1.5 million Americans are over the age of 55 and identify as LGBT. 37% of them had a kid at some point, compared to 74% of heterosexual Americans. What this says is two things. This says, one, people who come out later in life could have been in heterosexual relationships or bisexual relationships earlier in life and can have biological children because of that. So that says one thing. The second thing is it says that there's a decreased support system for these people as they age. They have less of their kids to take care of them as they age and everything like that. A lot of these people are more so families of choice than anything else. This is also a generation that was ravaged by HIV and AIDS, and a lot of people are no longer alive because of that. So that's probably why we only see 1.5 rather than, or 1.5 million rather than a much higher number from the AIDS epidemic. These people are more likely to be living single and be estranged from their biological family, and they're greater likelihood to be isolated. Interestingly, sometimes people will go back into the closet to live in a retirement community or a skilled nursing facility because they fear substandard care because of their sexuality. And then again, I feel like I've said this way too many times. Higher rates of hypertension, high cholesterol, diabetes, coronary disease, and HIV in these populations compared to their heterosexual colleagues. More likely to be depressed, more likely to contemplate suicide, more likely to be alone, less likely to have health insurance, and more likely to live in poverty. Coming out can happen at any time in your life. We were talking about people going back in the closet, having elaborate constructed narratives to protect their sexuality so they can live what they consider a normal life and not have to deal with substandard care or treatment. And we were talking earlier about the HIV epidemic, but 48% of people with HIV in this population have experienced a close death, which I'm surprised it's not much higher. Now talking about people of color, all the health problems we've been talking about previously, present. Problems is they're even more prevalent. So a lot of the time people who are in other minority groups and people of color groups can have religious beliefs and ideologies that conflict with their LGBT status. So religiosity. So that will potentially mean increasing internalized homophobia, externalized stigma and everything, which may lead to worsening chronic stress and an exacerbation of the chronic Myers-Stress minority model. Minority LGBT people are less likely to be open about their sexual behaviors with providers and more likely to be on the down low, which I feel like is not really a term we use very much anymore. And it was more about 5-10 years ago, but DL, down low. And this beautiful picture that y'all have seen earlier, that Latinx and African American peoples are more likely to contract HIV compared to Caucasian white people in the US. African American people account for 44% of new HIV infections, whereas African Americans only account for 12% of the general population. Latinx are 21% of new HIV infections and 16% of our population. So small population, but with a high prevalence of HIV in that population. And then this is going to sound absolutely wild. There is racism in the gay community. That I remember I've seen it many, many times on Grindr, on what have you, but basically where it's like, and please don't cancel me for saying this, but it's literally no fats, no femmes, no Asians. That's not uncommon, that people will say that they do not want to search for certain racial group or a profile or what have you, that people of color in the LGBT community can't say that they have experienced racism and bigotry because of their skin color, because of their gender expression, because of all of these different things. And that does occur. And then just estimated incidence of HIV across different racial groups. What we see is Black and African American people are highest early on, and then it tapers off over the years, and then transitions more to Caucasian white people. We're almost there. So now we're gonna, nice thing is we hopefully we'll be able to wrap this up in about 20 minutes and have a little bit of time for questions and what have you. Because I think that I've been talking a very long time and we're going near the end of time, I think. So drugs of abuse in, oh yeah, for people who don't know this game, this was Last of Us 2. If anyone watched HBO series, that's based on a video game, and then they made a second one called Last of Us 2. The main character is here, and she is exploring Seattle. And that's a LGBT bookstore in the post-apocalyptic Seattle. It's also called Last of Us Part 2. And now we're heading into part 2 of the presentation. So substance abuse background. So this is just general national survey on drug use and health in 2020. So people who used, LGBT people who used marijuana, 41.3% versus 18.7% of straight people, 6.7 to 3.6 for opioids, and alcohol 21.8% versus 11%. So we see higher rates of substance use in all of these populations. Binge drinking in the next few slides is defined as greater than or equal to 4 drinks for women and greater than 5 drinks for men. Illicit is what I mean when I say marijuana, cocaine, heroin, hallucinogens, inhalants, amphetamines, misuse of prescription drugs. All of this are illicit use of drugs. Substance use disorder. So substance use is just using. Substance use disorder is when someone has impairment caused by the recreation or recurrent use of substances. So just a few quick definitions. So all of the following slides are going to be from the Substance Abuse and Mental Health Services Administration 2023 report. So we're going to first talk about tobacco. And what we see is that there's higher rates of use of tobacco in the lesbian and the female bisexual community compared to the straight community. There's also slightly higher use of tobacco in the gay community compared to the bisexual. Bisexual is even higher, and then the straight male community is lower. What we're seeing is increased rates of tobacco use in our LGB community. And we also, this data doesn't have any trans data, so I won't be talking about that during the next few slides. And that's probably because of the sample size and how small that population is for this study. So now alcohol use, binge use, and then heavy use. So, in the lesbian and bisexual community, we're seeing higher rates of alcohol use compared to the heterosexual community. Same thing with gay and bisexual men. Binge use is also higher in lesbian and bisexual. Interestingly, it's lower in bisexual men for binge alcohol. Not sure where that comes in. And then heavy alcohol use is pretty constant across all male populations and higher in the lesbian population compared to the straight cohort. So basically what we're seeing is increased rates of alcohol use whatsoever in these populations. Illicit drug use. So talking about any illicit drug use, bisexual persons are higher in both populations compared to their heterosexual colleagues or cohort, and the straight community is less. We can see that marijuana is pretty high. However, any other illicit drug use besides marijuana is much lower in the teens to 20s range compared to 40 to 45% of marijuana use. And this was used in the past year. Talking about stimulants. So stimulant use is common. Apparently bisexual men really like cocaine. Not sure why. There's a few quizzical data points on here, but that's one of them. Like, why do bisexual men like cocaine so much more than gay men or what have you? One thing to look out for is how high methamphetamine use is within the gay community compared to other stimulants. Opioid use disorder. Surprisingly, even though opioid use disorder is more prevalent in the gay and bisexual and lesbian communities compared to the straight people, it's less overall. And then other use disorders are up on the screen as well. So kind of the summary for all those slides is substance use is common. Use disorders are more common. And the question is, why is this happening? And you can kind of say the etiology of it could be because of Myers stress, that drug use is more prevalent in this community because of all of the stresses that come that then cause people to use more substances. Great. I think it's more than that. I think there's also a normalization of substance use in the community, and in some points, potentially even an abuse. And we can also say that if substances are more available and more prevalent in different social settings, that a person is more likely to use, that the people around you do matter, and the social setting that you're in do matter and have some type of contribution to your use patterns. Okay. This is a meth pipe. Now we're just going to start showing a few photos. This is a meth pipe. So talking briefly about methamphetamine, this is when we're going to draw a few structures, and this is when I actually get into medicine talking about different drugs and things. So use of methamphetamines are 5.2% versus 1.2% in men who have sex with men versus women, versus straight people 1.2. This is from prior slides. So methamphetamine is a sympathomimetic. We have the structure of methamphetamine on the right-hand side that looks very similar to amphetamine, MDMA. So basically what methamphetamine does is it causes the release of norepinephrine and dopamine from the nerves and makes people feel good. They are more amped. They are able to do things. They have increased energy. They have some euphoria. Amphetamine itself has more central nervous system, so brain penetration compared to just amphetamine. And methamphetamine is metabolized to amphetamine. So what do we see with these people? So the route of exposure, so smoking versus injecting versus eating it versus putting it up your bum, have different routes of exposure, different times of onset, all the things, it matters. We're not going to get into that. When someone's just using normally, they can have some euphoria and increased energy. However, they quickly can develop other symptoms like agitation, tachycardia, hypertension, tachypnea, sweating, hyperthermia. I've been to Seattle a few times, and I think anyone who has been as well kind of knows what these people are kind of like, they're sometimes really mean. They're yelling, they're throwing things. I lived in a very transient heavy area of San Diego, and also same in Tucson, where methamphetamine was very common. These people, if they're using it on the streets, tend not to be the nicest of people. What are the long-term effects, though, of methamphetamine? So one of the big ones that we deal with is a type of heart condition called non-ischemic cardiomyopathy, and a heart failure that subsequently develops. And it's a heart failure that doesn't pump as well. So it's been referred to as heart failure with reduced ejection fraction. And then some, I've even found at least one citation where they call it meth-ref. Higher rates of pulmonary hypertension. So the right heart is starting to fail. Or I guess the lungs are kind of starting to fail, and the right heart has problems as well. There's a long-term cognitive impairment and a degradation, and a lot of these changes are irreversible. You can have an exacerbation of your prior mental health problems, and then can develop into a paranoid schizophrenia, lasting psychosis. A lot of these people don't care about eating, and they may develop malnutrition, not brushing their teeth. They also have bruxism, so they're grinding their teeth, which is one of the reasons why you can develop teeth like that. I love this because I always ask people, like, so is this an energy drink or not? Would you drink this? And invariably people are like, yeah, I'll drink that. That looks good. Looks like I'm going to get very excited because it looks exactly like a 5-hour energy. Now, if I was to tell you that this was at your local gas station at the cash register directly next to your 5-hour energy. Not only do we have that, but we also have these, which are varieties. You'll notice that nowhere on here does it say energy. It just has very pretty, colorful things. And you see things like room deodorizer, liquid incense, aroma. I've had plenty of patients who have thought mistakenly that this was a fire energy, took it from a gas station, just chugged it. And so what is this? These are a type of inhalants. So, and we'll get into that in a second. So inhalant use within the LGBT community. So gay men really love inhalants. That's kind of what the takeaway is. And same with bisexual men. And there's a very good reason why, but it's decently prevalent within this community. Inhalant use is actually, we don't see it in its data, but anecdotally, I've heard that we're seeing increasing rates of use within the straight cisgender gay community compared to the other communities. And that basically white cisgender women are learning about poppers. So now talking about inhalants. So basically what are these inhalants? So they're volatile substances that produce vapors. These vapors can be inhaled in different ways. So we can have sniffing, where you're like sniffing something off of things, where you're bagging it. So like Seventh Heaven down on the bottom right, where you're spraying something into a bag and then inhaling the fumes. You can have ragging it, where you take a rag, you spray whatever substances you have on it, and then smell it. Kind of like the old chloroform gag. And same thing with huffing. So there's many different types of poppers. Or sorry, different types of inhalants. You can have things like spray paint, which is on the bottom right. That's why he has that mouth. You can have glue, where people sniff glue, Sharpies, gasoline, toluene, so like a paint stripper, and then poppers and ethyl chloride, which are the ones that are more routinely used in the LGBT community, more so gay community. So these are poppers. This is what they look like. This was the prior slide that everyone saw. This is how it's used. So you're just sniffing it out of the bottle. So what are poppers? So they are generally sold as nail polish remover, DVD or VCR cleaner, or room deodorizers. And I'm putting those all in quotation marks for a good reason. If y'all were to walk into a local head shop or a adult entertainment store and try to buy poppers, they would say, no, we don't have poppers. It's illegal to actually sell and buy poppers. However, if you were to go in there and ask them like, hey, where are your room deodorizers? Where's your VCR cleaner? And no one has a VCR. No one even has a DVD player anymore. If you do, then maybe you have some of these in your house for that. My point is that why would they be selling these things unless it's for another reason? And it's just basically a way to obscure the fact of what they're actually used for. So what is in these? So there are different types of nitrites. Historically, there were amyl nitrites, and now most of them are isobutyl nitrites. So just the way that their structure looks. The symptoms that people have, so they have a euphoria, a flushing sensation, a warming sensation. When using them, it leads to decreased smooth muscle tone, where we can see flushing, so the vasodilation, and then also decreased rectal tone and relaxation. So people who engage in anoreceptive sex tend to use poppers more so than people who engage in anoinsertive sex, because it allows the anal muscles to relax so that they can engage in sexual behavior. What toxicity do we see with this? So the big ones that we see are methemoglobinemia. So what that basically means is that is a change in the hemoglobin so that your hemoglobin cannot carry oxygen, right? You can see cardiac rhythms that are abnormal. You can actually get an eye problem called pauper retinopathy and blindness with long-term use. And the final one is that it can actually cause a defatting dermatitis of the nose where people are sniffing them. Very interesting. Another new one is called ethyl chloride. And so this is a really old chemical that was previously used as an anesthetic and actually still is used in modern medicine. So ethyl chloride is an aerosol. You take it out of the can, you spray it, and you spray it on a rag, and then you inhale or you sniff it off the rag. So you rag. Medical uses. So because it's a propellant and then easily evaporates, it creates a cooling sensation. So it's actually used as a local anesthetic prior to orthopedic procedures like joint injections or things like that. It is a newer popper. Each one of these bottles is about $20. Poppers on the other one depends on the size. This is a little bit more expensive. The interesting thing is that these cause euphoria, a sense of lightheadedness and happiness. Long term, what happens is the molecule can diffuse into everything and diffuse into your nerves and brain, cause sedation, difficulty walking, dizziness, problems thinking. And I actually had a patient who was going through, I think, like 8 to 9 cans of this a day. And we wrote a paper on him. So this is a little while. Again, since I'm showing these, people probably will know what these are. So this is GHB. So GHB is gamma hydroxybutyrate. It's the thing directly in the middle. There's precursor ones, so like gamma butyrolactone, GBL. You can have 1,4-butane diol on the top left, and then also things like GVL, gamma valerolactone. What GHB is it's what we call sedative hypnotic, so it makes people sleepy. Other sedative hypnotics that we know very well are things like Ativan, Xanax, Klonopin, or even alcohol is a sedative hypnotic. It's a liquid that tastes bitter, and you're thinking, like, why do people use this? So it's quick on, quick off, lasts about an hour. You have to redose it about once every hour. And the reason why people use it is because it has a euphoria and disinhibition and everything that's very similar to alcohol. So people are using it in place of alcohol at parties. The other thing is, unlike alcohol, you don't get a hangover. So you don't have to worry about that in the morning, and you also don't have to worry about going to bed with the room spinning. The problem is the therapeutic index is very narrow. So if you were to double dose on the medication, then what you may have is you will have a pretty quick onset sleepiness, coma, sedation. People can get really small pupils, they can get low temperature, and then also low heart rates and low blood pressure. And classical test question for my boards or like emergency medicine boards is a person who comes in obtunded, needs to be intubated, tears out their endotracheal tube, and then storms out over a period of like 7 hours. And the question is, what is this? And that's a pretty classical presentation of what GHB is. And then the other weird thing is that withdrawal is possible, and people will be using this once every 3-4 hours, and even waking up in the middle of the night to use the G. And withdrawal like alcohol and any other benzodiazepine is possible. So horse tranquilizers. So ketamine. So names for it: K, special K. And I think this is like a very quintessential gay man drug. So it's an NMDA agonist. There's many different ways to use it. Most people just will insufflate it, so snort it, because it has the best bioavailability. The symptoms that people tend to feel are euphoria and happiness. However, you can overdose. And what that tends to cause is what we call dissociation. So when I'm describing it to parents so ketamine I use all the time in my clinical setting to help put bones back together, if basically make them go to sleep, especially in kids. So the way that I describe it is when someone uses too much ketamine, they disassociate. That means is when you go on vacation and you leave your lights on, but no one's home, that's what's going on. So you appear to be awake, but there is no thinking, no nothing, no memory recognition, no interaction, no nothing. They're basically like a living zombie. Other things is if we're at a slightly lower, so we call it the sub-dissociative dose. You can have hallucinations, you can have some sedation. This is when people start to have what they call bad trips. And then the other interesting thing is with chronic use, people can develop ketamine cystitis, so inflammation of the bladder. And that is really good timing. This is my San Diego family. They're great. This was PJ's Christmas party onesies year or so back. So this is a diverse patient population. There is a high prevalence of diabetes, substance abuse, hypertension, psychiatric disorders, mental health problems, infectious diseases in these populations. People who are young have their own special health problems, elderly have them as well, and people of color have everything that we talked about before. Trans patients require a delicate, sensitive approach, like you should approach every patient, but they have special ways to approach them. At the end of the day, a caring and supportive attitude is what matters most. If you don't know things, you can ask people. As long as you are there to like be on the side of the patient and you're not trying to demonize them or do anything bad, I think that people will be very willing and receptive of your care and compassion. Don't out someone, treat them like humans. And a lot of the time at the end of the day, why a person's coming into your ER, to your office, to your whatever you work at, it's probably not because of their sexuality. Maybe, probably not. And then with that, if anyone wants to email me, I'll just put this here for a second so we don't have to, actually, we'll just leave that there. Okay. My email is really easy to remember. It's gwink3@gmail. Super duper easy, simple. If you have questions, email me. If you want clarifications, email me. I'm open. At this time, I'd like to open the floor for any questions.
So we do have quite a few questions that have come in. I noticed that Huva is struggling a little bit to update. So if you refresh on your iPad, you should be able to see the questions, or 9 of them.
Okay, I'm gonna leave the meeting and sorry, on my iPad. Oh, well. Apparently I can't see any of them.
I'll just ask him. All right. The first question is, what interventions are recommended for LGBTQ young adults who are experimenting with drugs? Is peer intervention better than family?
I think that's a really hard question. And I don't think there is a right answer. That I think peer intervention, having friends and people who they value bring this up to them and bring up substance abuse, what have you, with them, and that they're concerned for them. Not every person in the LGBT community is going to have a good relationship with their family. And I think understanding the psychosocial dynamics that that person has with the people around them may be more important with tackling that. So I would say that if we have a person who there's a concern for substance abuse and misuse, that having their friends and their chosen family approach them in a compassionate, kind manner will probably get further than family itself. I know a lot of people who don't have great relationships with their family and it would not go well. And again, I'll say this, I'm not adolescent, I'm not a psychiatrist. There's like a lot of I'll say there's a lot of gaps in my knowledge. However, that being said, I can speak like as a gay man, as a person of the community, and what I think would work best.
So the next question is, what can be done for provider accountability in terms of providers' bias to sexual preferences being integrated into care management?
I think the best thing to do is to acknowledge the biases and try to move past them. The first part of correcting biases is understanding what your biases are, and then self-reflection, identification, and trying to move forward with that. We live and operate in a world where the default is a binary male-female, that the default is a heterosexual relationship, and it's sometimes hard to change the mindset and your own personal mindset. And at least acknowledging where you're coming from, what you're thinking of, all of those things will be the first step in improving that.
All right. What are some specific ways school districts can approach this in a proactive way?
I think that, so, oh my gosh, that's like, which part of the talk? Okay, so I'll just take a few things. So first, let's talk about substance use. So I grew up in Texas, where if you have sex at all whatsoever, you will die and you will melt, and you need to get married to have sex. And they don't teach protective protective anything. Condoms don't exist. Is that a smart idea? I think when talking about substance use in general, it's better to approach it like, hey, these are the things that are out there. These are the potential long-term risks. You should know about them before you do them so that people are armed with knowledge. So that's just talking about substance abuse in general. Now let's talk about what can school districts do for supporting LGBT youth. I think making it a safe, open, and inclusive environment for people to come to is the most important thing. So like counselor's office, having a pride flag, like in front, having a little thing that's a safe space, that goes miles, showing that this is a confidential, safe space that I can come talk to you about, and I don't have to worry about my parents finding out or my classmates finding out or anyone else. Also, creating institutional policies that help address bullying or other aspects that will potentially cause psychic trauma to the child.
All right, next question. Are there any efforts to provide LGBTQ specific recovery treatment services via rehabilitation and transitional housing?
I have no idea.
If any of you all in the audience have any idea, please feel free to put that in chat.
Yeah, you're also, I'll say this, like, I'm not sure about like Washington and the local things. There probably is, like, even in San Diego, There probably is. Problem is like mental health for teens and substance use for teens is really difficult to obtain at a baseline. I think it would be a great thing to have those kids surrounded by a social support system that's allows the kid to be themselves and talk about all of the psychological stressors and be supported for them. I also live in Texas where it's almost upbeat, don't say gay. So I know my limits.
All right, this is a big one for your last minute.
Okay.
How much of 2S LGBTQ health disparities in medical practices are rooted in white supremacy culture and Christian nationalism? What can we do as POC besides educate to reduce this harm caused by these systems?
I think a lot of I buy the Myers minority model. I think it's a little reductionist, but I think that a lot of what we deal with as a society and what health problems we deal with and substance use and all that are partially within that. I think that a lot of what we are dealing with is because of our nation's history. So the next question is, how do we support combat that? I don't know if I have the best answer. I think creating policies, procedures, and trying to undo some of the problems that have happened with time is probably the best step towards the future.
All right, thank you, Dr. Winkler. We are 1 minute over, so we will let folks go to their next session. There are a few more questions in there, so maybe you can take a look eventually. Some of them are also just about linking studies, which the slides will be uploaded, so you all be able to access that information.
Cool.
All right, thank you so much. This was incredible. I learned so much. I'm sure everyone else did. And we will see you all in the next session, everyone.
Bye, y'all. Thank you.